is that because like their affinity for like their hemoglobin is higher or something, or is that why it could be fatal? Like it could cause like bursting red blood cells or something. I didn't know why. So
Yeah, so there is such thing as iron toxicity, right? So if you have too much iron in your body, you end up basically putting that iron somewhere, right? Iron, have you guys heard of iron overload? I talked a little bit about it in sickle cell disease, right? It can cause your some organ failure, etc., to occur if you store too much iron. Um, so it's more from that perspective. If you take too much in too quickly, then you can have kind of more acute type of scenario occurring from that perspective, um, where it could cause some mortality to that patient. And that's the issue is more from the kid perspective, right? If they get into grandma's iron tablets, right? Or something that it's a much higher dose than what they are supposed to be getting by far. That's why it's more of a problem for a kid than like an adult to potentially overdose on it. Either an adult is probably going to know not to swallow the entire bottle, hopefully. And if you ever seen iron, it looks like red little candies, kind of. It doesn't taste that way if you chew on it, but they kind of look like small red things that could potentially be misconstrued as candy. So that's where the potential could come across that way for a child. And I see in here normal ranges for lab values. Yes. So I will either on the exam, I will say this is a low number, this is a high number, or give a normal range next to it. You don't need to memorize that part just yet. You know, future self for NAPLEX, there are going to be certain lab values you do need to kind of have an idea. But for my exam, you do not need to know that. Good questions. Good questions.
I had a quick question, Dr. Higgins. Going back to anemia for the review that you posted when you said know the big table that helps differentiate between different types of anemia. Is it like that big table that you have in your study guide, like assessing the laboratory values?
Yeah, let me just hop back. I will, since you mentioned study guide, I will pull it up just so I can share it with everybody so you all are for sure on what table I'm talking about. Let me gotta find the right folders, all sorts of folders, right? And also, Matthew, did I answer all your questions?
yeah, I think you did for the most part. So like basically just going based on that review lecture. So with the pharmacological treatment, did you want us to know the side effects with the treatment too, or just the treatment in itself for anemia?
Best treatment.
Yeah. Okay.
You'll need to know side effects at some point in your life, right? For that. But the big things for the exam purposes, signs and symptoms of anemia treatment. All right, let me get down to where I'm talking about. So this table, y'all see this table right here. This is the one you need to kind of really have a good grasp on because you might get data given to you and you have to decide what is it iron deficiency anemia? Is it anemia of chronic disease? Is it vitamin B12? Is it folate deficiency? What is it, right? Okay. Any other questions? Otherwise, we can get to this, which might help a little bit too, of kind of just running through examples. Oh, disease modifying agents. You want us to just focus on the routes as well, or just pros and cons. So for question sickle cell disease modifying agents, be thinking about what are the pros and cons of, and we're gonna go kind of through that in this case here. So we'll cover that for sure here today. But part of the pros and cons could potentially be route. So be including that in kind of your pros and cons list, okay? Does that make sense, Jody? Okay, perfect. All right. Let's run through these and then I'll have time for questions too. We'll do that too. See if this answers everything as we go through, if there's other questions. All right, so TK is a 23-month-old Hispanic male. His weight is 16 kilograms. He presents to his pediatrician for a sick visit. His mom notes that his naps have been lasting longer than usual, and she noticed his eyes look pale. So when, just like here in the picture, you pull down the lid and we look at the conjunctiva there, and it's kind of a lot less red. It's more whitish than it should be, right? And she also notes that he has been eating sand in the sandbox at daycare. So first up, so a lot of this is going to be open-ended because if you can figure through open-ended questions, multiple choice questions are a lot easier, right? So we're going to have a lot of open-ended discussion here today. As I said, all multiple choice for the exam though. All right, so additional questions. What are you going to want to ask mom to sift through this information to gather information of how to make a diagnosis for this patient? What foods does TK typically eat? Good, good. When did he have if he had an iron test, when did he last have one? Sure. What other questions would you want to ask mom? Does he drink a lot of milk? Yep, so that could go along with the typically eat. What's your dietary habits for him? Family history. So is there a family history of anemia? Good. What other things could go history-wise into our differential here? Are there dietary restrictions? Vegetarian, sure. Medical history. So past medical history of the patient, great. And blood or urine in the stool. Perfect. So that is one that gets forgotten a lot, right? So you guys hit most of the big ones I was thinking of. Eating habits. That's going to encompass food, drinks, whatever that is. And if mom gave you answers that didn't necessarily get to the bottom of what you needed, that's when you could be like, oh, how much milk does he drink? Or, is he able to eat meat, etc. So if that isn't shared immediately, presence of blood and stool in the urine, that one's forgotten a lot, right? Because blood loss kind of, I think, is forgotten sometimes for the process of anemia. So remember, it's three-pronged, right? Production is one part of the problem. And yes, that's most of the time what our pharmacologic treatment is focusing around is production, but destruction and blood loss also can be a reason. So you need to rule out those things in order to kind of sway you of saying, okay, this is probably a production issue, right? Without having labs. So presence of blood or in the stool or urine, past medical history, because maybe whatever they have going on for a disease state could put them at risk for that inflammation of chronic disease or inflammation or anemia of inflammation. It could also have certain meds they might be on that might put them at risk, right, for anemia. And then family members having anemia, because sometimes it runs in the family. All right. So what lab values do you want to get? So next up, we've got our signs and symptoms kind of in place here. Talked about history. CBC, yes. So we need a CBC. What else? That goes along with the CBC. Got iron panel, hemoglobin hematocrit, RBCs. So we'll get all that from CBC, folate, B12. What other things could we, reticulocyte. So yeah, so reticulocyte index isn't automatically show up on a CBC. That's something else you have to order. And then something else. So if we see a low hemoglobin, ooh, yeah, I saw occult blood. That's another one. Great. Occult blood of the stool, because sometimes you can't see the blood if it's not frank blood, right? Or if you don't have dark tarry stools. So Sometimes you might not see the blood necessarily, so sending an occult blood is great. And then another aspect. So what else do we need looking at that chart that we haven't said just yet that we need? So we have we're saying we're getting our iron panel, B12 folate, we're getting a CBC, reticulocyte, something that doesn't come automatically on a CBC. Yeah, I see it. MCH. So MCHC, MCV, those things we need to know. And that's technically what we call an RBC indice lab. So that doesn't automatically show up on a CBC. So a CBC is literally just white blood cell, hemoglobin, hematocrit. There's probably an RBC number down there and platelets. That's about it. So if you need more information, you have to order the other labs part. All right, we hit everything I was thinking about. Specifically iron panel right now based on history, but I'm going to kind of give you some labs. So this is what we have as our lab values. Hemoglobin's 5.4, MCV 60, reticulocyte count is 0.3%. So everything's low. So what are you thinking right now based on this information? What type of anemia? All right, yeah. So a production issue, it's microcytic, and microcytic equals iron deficiency anemia most of the time. Or potentially that anemia of chronic disease or anemia of inflammation potentially. So it can be a little hard to differentiate between the two. So we need what at this point? Levels. What kind of levels? Yeah, so we need a ferritin. What else is on? TIBC. What else do we need? Transferrin, yep. All right. And then an iron level, so don't forget that one. All right, so serum iron is low, TIBC is high, ferritin is low, transferrin saturation is low. So what are we thinking? Does this confirm your thoughts? Or is this... So getting a few coming through, iron deficiency anemia. Yeah, so this is what confirms iron deficiency anemia versus our anemia of inflammation, or also known as anemia of chronic disease. Good. All right, so now we have a diagnosis. What are we going to do to treat? Start with non-pharmacologic treatment. So what can we recommend to TK's mom? Iron-rich foods. What are the specific foods or etc.? So, all right, we got beef, fish, animal liver, meat, red meat, spinach, I saw in there, eggs, poultry, lentils, fortified cereal. Good, good. That's a great one for his age group. Tofu and beans, potentially. Avoid milk. Yeah, so why would we avoid milk, right? There we go. I see it in there. Avoid milk and tea. It'll decrease the absorption. Good. All right. We hit pretty much all the big ones there. So his age group at almost 2 years of age, you probably like cereal a lot. That's a great one. He, depending on what his eating habits were like, trying to get more meat in him because meat is where a lot of the best absorption of iron is going to occur. If they are vegetarian, then that's where we need to work more on tofu, lentils, beans, spinach. Potentially eggs if they eat eggs. All right, so he's low enough though that we can't just do non-pharmacologic, right? So his hemoglobin's 5.4. We got to do something a little bit more than that, right, for him. So what pharmacologic treatment would you recommend? Oral iron. So what type of oral iron would we do?
iron salt formulation or with elemental iron percentage?
Yeah,
Like
so
ferrous sulfate?
what specific iron salt would work well for this age group?
Um,
And this part you wouldn't necessarily have to do on exam purposes, but we have Fe2 elemental iron. So elemental iron is what we're going to dose off of every single product. But looking at those products, remember 23-month-old. Yeah, I'm getting a couple ferrous sulfates. Yeah, so ferrous sulfate is probably the one that comes in most amount of liquid options, right? So he can't swallow a tablet or a capsule just yet. So looking to make sure there's a liquid option. This part you would not need to know for exam purposes. It's just I'm trying to work through the problem with you to kind of get you to be thinking to those levels for future potentially. Okay, because I know we do have a anemia little APC lab. I know it's not quite aligned with this because it's with the Dr. Kern's part and some historically exam 2 is a little harder for people, so I chose to align the Dr. Kern's part with Dr. Kern's material. So we provide feedback after if you feel like it should be aligned differently in the future. But all
Um,
right.
I had a quick question. So
Yeah.
why is ferrous sulfate? Because just going based off like your material, it said that the elemental iron percentage of ferrous fumarate is a little bit higher, like 33%. So why choose sulfate over fumarate?
From the perspective of liquid formulation and readily available liquid formulation, I don't know how many of y'all work in
Okay.
pharmacies.
Yeah.
Usually ferrous sulfate liquid is by far the most common thing that's going to be on the shelf. Yeah.
Gotcha. Okay.
Um, and it comes in a few different things of solution, syrup, elixir. So if like you don't want to give alcohol formulation, you can be able to give something that has maybe a little less alcohol in it in comparison to some of the others. So there's a lot more flexibility in the dosage form for ferrous sulfate for this aspect of a child. Iron tastes terrible though. So that is one thing. None of these are going to be wonderful for a child. It is disgusting tasting. You would think about it like basically sucking on a penny or something, right? It tastes terrible. Are they interchangeable? So it wouldn't be a one-to-one interchange, right? For any of these, right? Because the different percentages of elemental iron, if you dose appropriately off of the elemental iron for that between the two, you're not going to get the same milligram potentially or ml volume. You probably have the right milligrams if you're dosing appropriately of elemental iron. It's just your volume may change depending on what formulation you pick. Does that make sense? Okay. All right. Which medication should be stopped if possible to increase iron absorption for him? And we'll say we haven't gotten to that question yet. We're doing the first question. So, first question, if you were, what medications, not knowing what he's on, what medications would potentially impede absorption of iron that we would want to? All right, yeah, PPIs, antacids, H2 blockers, yeah. So the big ones are medication wise would be anything that can increase our pH, right? Because we need a acidic environment for iron to absorb best, right? So that's one of the reasons why we usually say make sure you take your iron with vitamin C or orange juice is because that's going to help the absorption, right? And so if we decrease that, so with a antacid with a PPI or H2 blocker, or if we give an antacid that can bind to the iron and not absorb, those are all things that we would want to avoid. All right. So when should labs be repeated? I saw an answer up here already. Let's see. Does anybody else agree with that answer? Yeah. See, 2 to 3 months. So yeah. So, and I can't remember how I tied this in on my recording so much, but remember, red blood cell lasts 120 days, right? So we can't check back within a month. That's not going to be so reflective of that because we haven't made more and had enough time to be making more and in order to catch up, right? So at least needing wait 2 to 3 months before so that you have a better picture of new production by that point. And our next question, Dahlia, you're jumping out of here. So our next question is how long should treatment continue for? And the big thing here is yes, the 3 to 6 months, but really noting your time after anemia is resolved, right? So you have to have that 2 to 3 months that was before you checked your labs doesn't count towards anything. You need to have your anemia resolved and then continue another 3 to 6 months because we're still building up stores, right? If we stop at that point where the anemia resolved, we're probably going to drop back down. All right. So it's more, I got a question. How do you know it will not reoccur? So if you continue for the 3 to 6 months, that's going to give you best. And then you need to fix the underlying problem, right? So figuring out why they were iron deficient to begin with. So maybe he was drinking a gallon of milk a day or something like that. So fixing the underlying problem will help you to make sure that you do not reoccur once you stop your iron. And sometimes there isn't a way to fix the underlying problem, right? Sometimes it might not be very easy to fix the underlying problem if you had something multifactorial going on. Maybe it's a disease state that's causing them not to absorb very well. Well, then they might be stuck on iron for a long, long time after that. All right. Feel a little more comfortable with anemia after running through that? All right. Case 2, so 23-year-old Black female with hemoglobin SS, sickle cell disease. Her past medical history, she has splenic sequestration in her history, vaso-occlusive crisis about 1 to 2 times a year, requiring admission, and acute chest syndrome last time was 1 year ago. She also has asthma and nocturnal enuresis. Her past surgical history, she had a splenectomy 10 years ago, cholecystectomy 5 years ago, and the patient states she does not take any medications at all right now. So starting from kind of the beginning, what infection prevention strategy should she be receiving at this point? Yep, so hopefully she's been fully vaccinated for her pneumonia vaccine. If not, she needs to catch up. Perfect. What else? All right, I see. Penicillin. Yes. Why would she be on penicillin? Still. I know I talked about it. There's props 1, props 2 study, right? We said we could stop at 5, right? Why should you be on penicillin stay? Yeah, splenectomy. That's the key. So she had a splenectomy. She doesn't have a spleen anymore. So that is one of the reasons she's more at risk for these encapsulated organisms. And I know you haven't had ID yet, so you'll get more information on that in the future, but there are certain organisms, if you don't have a spleen, like meningococcus, strep, pneumo, and Haemophilus influenza, that you're more at risk for. So perfect. All right. So she should be on penicillin, up to date on her vaccines, especially pneumococcal, but don't forget these other ones like meningococcal and Hib. And then she should get her influenza vaccine every year. But that's not something different for sickle cell. Everybody should have their influenza vaccine every year. All right, she is now admitted to the hospital with chest pain. She has max temperature of 40 degrees Celsius. So that's one thing to kind of keep in mind is in inpatient world, everything's in Celsius and kilograms, so metric system type of thing. So You got to get used to kind of internalizing. So 40 degrees Celsius is a fever. It has a new pulmonary infiltrate, and this is 1 week after being discharged from an admission for vaso-occlusive crisis. Her O2 saturation on room air currently is 96%, and her hemoglobin stable at 7.2. So at this point, what sickle cell complication is she experiencing likely right now? You got ACS. What's ACS stand for? Because that could be that's a few different acronyms in medical world that go by ACS. Yes, acute chest syndrome. So it's not acute coronary syndrome, acute chest syndrome that we are focusing on for this one. Perfect. All right. So what treatment would you recommend for her, and what is this covering based on the treatment? All right. Potentially supplemental oxygen. She's on room air right now at 96%. She probably doesn't need supplemental oxygen at this point, but if she drops lower, antibiotic therapy. Okay. All right. Yes. So I got a direct message: cephalosporin plus an azithromycin. Specifically, it's a 3rd-generation cephalosporin because that's going to cover some of your gram negatives as well as your strep pneumo. And then IV fluids. Yep, we need those. So something you will get more of in ID is kind of bug drugs. So that cephalosporin is specifically there to really be the best coverage for the Streptococcus pneumoniae. And the azithromycin is covering what we are usually referring to as our mycoplasma pneumonia and chlamydia pneumoniae. That's what they are, that's there to cover. So those are the top 3 usually bacteria that these patients, if they do present with acute chest syndrome, because we can't differentiate, is this basically a vaso-occlusive crisis of the vessels in the lungs, or is this a pneumonia? We can't tell without doing a bronchoscopy, which we're not going to do a bronchoscopy at every single patient, right? So from this perspective, we have to treat both, right? So we're going to give her IV fluids to make sure we are hydrating her well and making sure that we're helping with the vaso-occlusion potentially, but we're also need to cover for potential pneumonia. So these are the most common things pneumonia-wise. All right, so how could you prevent this in the future? Yes, hydroxyurea. So that's the big one. And spirometry, and why she's in the hospital, make her not get more basically worse acute chest syndrome. Or usually we're not going to tell them to do spirometry usually at home too much. It's whenever they're inpatient to prevent them developing an acute chest syndrome while they're inpatient. But during her hospitalization, she should be doing her incentive spirometry because that has been shown to decrease your risk by a ton, like 80-something%, right? So, and then start hydroxyurea. So that is the big thing to note. She said she wasn't on anything. At 23, she should be on something, right? Hydroxyurea is it because we are supposed to be offering or recommending to a 23-year-old to be on hydroxyurea. Yeah. Seeing some answers coming through. Recommend. So there is enough data to say that every adult with sickle cell disease, whether you've had complications or not, should be on hydroxyurea as preventative strategy. Either it's preventative of having these vaso-occlusion crisis or acute chest syndrome, or likely by that point, it's going to be secondary prevention, right? They've probably have had those things in their past. It's now preventing that from happening, hopefully in the future as much. So she should be on hydroxyurea. Now, a child starting at 9 months, that's when we open up the conversations with families of this is something that has been shown to have some benefit. We just don't have a lot of long-term data just yet. Because At 9 months, they got quite a few decades to live after 9 months of age. And yes, it's been a while since the baby hug study first started, but we don't have like 6 decades worth of data to say that, by the time you reach your 60s, you aren't going to have any sort of weird complications come up, long-term complications come up from being non-hydroxyurea from when you're 9 months old. So that is why it is not a recommend just yet. It is a offer. Question came in about the recommending offer. So we just went over it. So this is what you need to know, right? Right now, based on guidelines that we have, there isn't anything else that has enough data to say this is a preventative strategy, pharmacologic wise. There's non-pharmacologic things that for like what disease state do we have this hydroxyurea not necessarily work so well at preventing just yet that we know of. And we use something different that's not necessarily pharmacologic. It doesn't come from the pharmacy that we're dispensing, but it is a preventative strategy for primary and secondary. And I actually think it's coming up on the next one, so we'll jump to that. So 3 months later, she's admitted with hemoptysis, headache, and facial droop. What do we think she has? Stroke. Yeah. So those are stroke symptoms. What are we going to do to treat this immediate stroke that she's having? IV fluids and transfusion, right? So it's either a simple transfusion or an exchange transfusion, depending on what her baseline hemoglobin is. So remember that exchange transfusion is literally we have one line coming out with the blood. It goes through a machine that is taking out removing her blood and giving back new blood back into her. So we're able to kind of replace blood. Where a simple transfusion, we're not replacing the blood, we're adding blood to her to kind of hopefully dilute out some of that hemoglobin S and give some more hemoglobin A back to the patient. So a lot of times it's an exchange transfusion. There's very few aspects where it would be a single transfusion from that standpoint, but that is kind of leading to the non-pharmacologic, right? Transfusion is not pharmacologic, but it's still important to know from a pharmacy standpoint because we need to be able to say like, hey, hydroxyurea is not going to work here, right? It's not going to work for treatment here. You need to do something else, right? All right, so secondary stroke prevention. Now what do we do? Yeah, she's going to have lifelong chronic transfusions. It's usually every 3 to 4 weeks. So this is right now where the data with hydroxyurea is lacking. So hydroxyurea right now has not been shown to be the same or better than chronic transfusions. So we are still stuck with that management even for now. Hopefully maybe some point in the future we'll have some either hydroxyurea gets better data or we get one of these other disease modifying agents that gains more data and outweighs chronic transfusions. So chronic transfusions can cause what kind of complication? Volume overload, okay. What else other than volume overload? Iron overload, good. We got another one. Alloimmunization, yeah. And delayed transfusion reaction. Good, we got them all. The volume overload potentially, if we are not taking into account what fluid status they are at the moment. Alloimmunization is a big problem potentially because you can start to basically develop reactions to your immune system recognizes this chronic transfusion as being foreign and we need to look for even HLA matched blood, which makes it harder and harder to find appropriate matches for the patient, and be able to get that blood supply. Delayed hemolytic transfusion reactions is a problem, and then iron overload is kind of the pharmacologic problem that we think of the most, right? Because that's something that we potentially have a way we could fix pharmacologically from a pharmacist standpoint. All right, so 9 months later, oh, she has an elevated ferritin and her MRI is concerning for iron overload, we'll say in her liver. What treatment would you recommend at this point? Iron chelation therapy. Okay, what would be an example of that? Defersirax, deferoxamine, okay. They're one that we might use over the other. Why pick defersirax versus deferoxamine, or why pick deferoxamine versus defersirax? And there's a third one too. But PO versus IV, yeah, right? And then deferperone is the third one, yeah. So we'd likely want to pick something oral because we don't want to commit her to having infusions of deferoxamine, either IV or sub-Q, to be done. So we don't want to have to do that necessarily. So we would pick something oral. So that would leave you down to defersirax or deferperone. Deferperone is 3 times a day. Defersirax is once a day. So that leaves you with that one. But then there's 2 formulations of defersirax. So how would you decide between Xjade and Jadenu? I'm gonna give you the answer here. I forgot that had the brand name there, but why would I pick Jadenu over Xjade? What's the difference between those formulations? Think about that. They're both oral, but what's the difference about their dosage form? Easier to administer. Why is Jadenu easier to administer? Yeah, we gotta swallow whole. The Xjade is basically a wafer you have to mix in water, water or apple juice, etc., to dilute it and drink it, right? So it's a lot easier to tell somebody to swallow a pill, right? You do not need to know brand names. Just need to be able to differentiate between the iron overload choices specifically, because it might be a similar situation, and I might say they are terrible at taking oral meds and they want something IV. So you just need to be able to tell the difference between there. So I would kind of be focusing more on oral to IV, what's daily, what's 3 times a day, to kind of be able to make your decision there. So similar thought process, just what we went through, but you don't need to necessarily be able to tell the difference between Xjade and Jade. Okay. All right. I think somebody was jumping on my next one. So we got administer on an empty stomach or with a light meal for Jadenu. What happens if I can't swallow the tablet? What happens if I say she can't swallow it? Remember, she's had a stroke 9 months ago. Maybe she hasn't regained all of that back just yet. Can you crush it? What do you think? Do with a light meal in here. I'm not sure if that's taking it with a light meal or crush. Yeah. So you can actually crush the Jadenu tablets. And it can be put in with soft foods such as your applesauce if you can't swallow it. So makes that a very desirable formulation. So what are some common side effects? Just to get you thinking through some of these things. Not that necessarily that it will be a focus, but I want to make sure we've thought through everything in this patient situation. GI upset, great. What's another kind of common thing that goes along with some meds? Nausea, probably go along with GI upset. Good, good. What else? Skin rash. A lot of times, I feel like a lot of oral meds, it's pretty common to see GI upset or potentially some sort of rash come across with them. So, and these are not uncommon from that perspective. That's usually a good counseling points to kind of talk about with that for this drug. All right, so she's unable to stay compliant with her chronic transfusions, but has been taking her hydroxyurea. She wants to think about other disease state modifying agents. So what would you add to hydroxyurea since she has so many complications this past year? It's been a bad year for her. And what would be the pros and cons for those agents? So let's think about what's the other disease modifying agents? What are the other options? Got L-glutamine, okay? What's the other two? Crizanlizumab. What's the last one? Voxelotor. I feel like it's like the name of a superhero or something whenever I say that. All right, so we got all three. So L-glutamine. What's a pro of L-glutamine? Oh, can you put the previous slide one moment? That one? I'm going to post all these for you, so don't get too in the weeds. All right. All right, reduced number of pain episodes and hospitalizations. Great. Yep. So that is a good aspect, good patient type of endpoint, right? We know vaso-occlusive crises and hospitalizations are a problem. That's a good thing that we can see that decreases. Great. What other? Maybe think of some cons. What are some cons to L-glutamine? It's got some side effects, some GI things. Frequent dosing, yeah, so it's twice a day. What other things? Think about dosage form. Is that easy to administer? Oral. Yeah, it comes in a packet, right? And we're going to mix that packet with something to be able to give it. And also, depending at her age, she's likely needing multiple packets per dose. So it gets complicated from that perspective of so that patients they might be thinking, oh, I just need to do one of these packets. Sometimes they got to do 3 of those packets per dose. So it's needing to have a good amount of education there in order to not do it wrong, right? All right, crizanlizumab, what's a good pro for that one? %45 reduction in what? Vaso-occlusive crises, yeah. Yeah, so it has the best data in decreasing your vaso-occlusive crises and admissions data right now, but what's the con? Right now, right? It sounds great. We should put it on everybody, right? That's kind of the cons behind it. It's IV, right? And we get all the side effects that can come along with it because of infusion reactions. Perfect. And the last one's voxelotor, but somebody did point out in here, it has been taken off the market recently. Probably because of the cons I talk about in here. So pros were its tablet formulation and daily dosing. That was great from that perspective. Cons is multiple tablets per dose. We got lots of drug interactions. And it wasn't ever linked to decreasing vaso-occlusive crises, right? It was linked to increasing your hemoglobin, which potentially could be extrapolated that it theoretically should decrease these things, but it never was demonstrated to decrease your kind of other endpoints like the L-glutamine or crizanlizumab have been. All right. So, some practice with more other types of questions. So having multiple choice. So what is a cure for sickle cell disease? Is it crizanlizumab, voxelotor, hydroxyurea, or allogeneic stem cell transplant? Lots of people tell me allogeneic stem cell transplant, and you are correct. So our disease modifying agents are not cures, right? They're going to hopefully decrease complications, hopefully then by decreasing complications, you're extending life for that patient. But they're gonna take the medicine forever, right? Once you kind of start it and it starts working. Stem cell transplant is the only thing that will be a cure because it's an allogeneic stem cell transplant. Basically, you're getting a new bone marrow, you're getting new blood, etc., from another person. But there's a lot of debate on do you go for this or not if you don't have a matched sibling donor. So matched sibling donor has the best data, but matched unrelated, you have a little more risk with it because of graft versus host disease being higher. And we're going to talk a lot about that. I think it's like exam 4. So you'll get more on stem cell transplant then, but just be aware, the only cure right now for sickle cell disease is an allogeneic stem cell transplant. Gene therapy, who knows? We will see what happens with that. We don't have a ton of data on that because it's only been out for a little over a year. All right. Last hematology case. So SB is a 65-year-old white male who presents to his PCP for annual physical examination. Past medical history is seizures, seasonal allergies, GERD, and hypertension. These are his medications. Pertinent labs, got a white blood cell count of 1,000, hemoglobin of 7.4, also a lower hematocrit of 22, platelets of 15,000, and his ANC is 350, and he's basically making no reticulocytes. So what do we think? What do we consider what are we thinking about his diagnosis right now? Aplastic what? Anemia, yeah. What type of aplastic You won't necessarily need to do this on the exam. But so remember there's categories severity wise of aplastic Which one is where does he fall based on our labs that we have? By far, these questions are harder than what's on the exam. Severe, yeah. So he's severe aplastic anemia. He's not very severe because his ANC is above 200, but under 500. All right, so some of you gave me this answer earlier, but which of the medications puts him at risk? So this is his current medications. Which one was putting him at risk for aplastic anemia, potentially from a drug-induced standpoint? Yeah, seeing lots of carbamazepines, and you are right. So, how would we treat him? What's the first thing that we got to do? Remove the med. Good. I don't know how many times I've this has come up from not necessarily this specific aspect, but a lot of times in practice, the providers sometimes forget to actually stop the med that they actually identified as being a problem. So we got to stop the medication. Perfect. So this one, because it's a seizure med, we're gonna have to taper it off. We can't just stop it automatically as we're adding a different anti-epileptic on. We got to provide RBCs and platelet transfusions. Perfect. He's got a low ANC. What other things would we need to do? You comment in here about GCSF. GCSF, it's still controversial on using, but we do need prophylactic infection. So we want to prophylax him for bacteria and fungus at this point. Perfect. And then what happens if this doesn't work? What happens if we are having to give platelets and RBCs multiple times a week for weeks? Stem cell transplant potentially, but what might we try first before going to a stem cell transplant, especially if the stem cell transplant, we don't have a matched donor right away? Immunosuppressive therapy, I saw ATG and cyclosporin. What type of ATG? I don't necessarily go over that in here, but what type of ATG? Horse, yeah. So this is the one that horse ATG has better data than rabbit ATG. When I talk about stem cell transplant free wall in the future, ATG will come up again, and that one actually rabbit has better. This is like one of the niche areas that horse ATG has the better data for. But you're getting immunosuppressive therapy at this point, and knowing ATG plus cyclosporin, you're good. All right, so what medication has a risk factor for causing agranulocytosis? Oh, look at that. Well, let's put it back. Which one is it? Apparently, I had my thing was not working. Is it methimazole, respiricase, metformin, or quinine? Yes, methimazole is likely the drug that could be causing agranulocytosis out of that list. Gotta fix my animation there. All right, so what disease state causes metabolic hemolytic anemia? It's not a drug. What disease state, if we give certain drugs in that disease state, could cause hemolytic anemia? G6PD, so glucose 6 phosphate dehydrogenase deficiency. So yes, perfect. So G6PD is a big risk for hemolytic anemia if you're exposed to drugs that you shouldn't be exposed to if you have G6PD, and it's through the metabolic pathway. So mechanism behind that one is metabolic, where other causes of hemolytic anemia usually are not through the metabolic pathway. So key difference there to kind of keep in mind. All right, so that's my hematology problem. I got intro to oncology questions to run through, but does anybody have hematology related questions right now?
So for that sickle cell case that we did you want us to know, like, so I don't know if we went over it, but in your notes it mentioned stuff like initial pain management, like what we need to know between like opioids, the analgesics, like
So
anti-inflammatory. Sorry.
yeah, so the exam review kind of gives a hint on what complications to focus on. So I would refer to those exam review slides. So I know there's a lot of complications in that lecture, so I was trying to give a little more educated guidance there for you. All right, any other hematology questions? Was that helpful? Kind of run through those? Also, thank you for pointing out about the Voxelotor. I actually didn't catch that one that it got removed from the market from this past fall, winter. So thank you for pointing that out. I will make sure to update my slides for next year to add that in. But I will thank you for pointing that out. Yeah. Sometimes we aren't perfect, right? All right, so intro to cancer practice examples. Most of these are going to be, oh, well, that's supposed to be animated. Kind of gave that away. All right. Let me, actually, I think I have the wrong slide set up. I think that's the problem. I have the slide set with the answers and it's not animated. Let me pull up the slide set without the answers in it and then I can post the ones with the answers. We're all human, right? Human mistakes sometimes. Maybe you didn't see it originally, but so we have a 45-year-old Hispanic female who's interested in cancer screening. What screening would you think she may need? Breast cancer, yeah. So right now I haven't taught you about age ranges of when screenings would happen, so we don't need to necessarily take that into account. So breast cancer, what other things did I talk about could have screening? Yeah, cervical cancer, great. Colorectal, perfect. Lung is on the list, but it's when we get to lung cancer, you'll find out why she probably doesn't qualify for that, or we would need a lot more information to decide that. But right now, those are four she would qualify for. What does she not qualify for out of what I talked about? Prostate, right? She doesn't have a prostate. So we don't need to necessarily screen for that. If it was the flip way, if I made her just a 45-year-old Hispanic male, then breast and cervical would probably be coming off the list, and prostate would be on your list. All right. So I'm going to kind of talk through these answers, but when I post, I will post with the answers. Need to animate this next time. All right. So 56-year-old black male who has had a nagging cough for past 3 weeks. He thought it was just leftover from a cold he had a month ago. He recently noticed he developed hoarseness and feels like it's been more difficult to swallow lately. What would be kind of your warning signs or symptoms going on for this patient right now? What sticks out to you as being kind of those warning signs or symptoms that are in the lecture? Difficulty swallowing, yep. Nagging cough. I got the caution acronym, but not all of those are present. So which ones? We got nagging cough, difficulty swallowing, duration of cough, the nagging cough, hoarseness. Yeah, great. So all of those are things that are going to be concerning for what type of cancer? What are we thinking this puts them at risk for? Lung, yeah. So these are all potential signs or symptoms that somebody with lung cancer could be presenting with. All right, so we got a CT scan performed. He does have indeed a spot on his lungs that's 5 centimeters in diameter. The doctor performs a biopsy and it results as non-small cell lung cancer. So we're not going into details, but based on the intro lectures that I gave, what staging strategies would that doctor likely be utilizing at this standpoint? When I talked about staging, I talked about a couple different options. So T&M, yeah, great. So what does the T and T&M stand for? Tumor. What's the N stand for? Node. And what's the M stand for? Metastases. Perfect. Yeah. So the T part is tumor. So what's the size of the tumor? That's going to give us information, and then N is the number of nodes involved, and then M is there metastases or not. And that information is going to bring us to what Dahlia put in the comments here, numerical staging. So at that point, that's going to help us determine stage 1, 2, 3, or 4. All right. Any questions on that? So not all staging systems are going to be the same. This is an example, and the easiest example to kind of go through when I go through each disease state, or when Dr. Steva Cheemer goes through, because for DE, I split with her for this. So when she goes through some and I go through some, you may see some varying staging systems being utilized from the TNM and the numerical staging. Just kind of keep that in mind, but these are more common, probably the more common ones for our solid tumors. So those are things like lung cancer, colorectal cancer, breast cancer, etc. Or our hematologic malignancies like leukemia, lymphoma usually have a much different staging. All right, so going to our RECIST criteria, which is how we kind of see the progress of a patient with a solid tumor. We use this RECIST criteria. So now this patient has had 2 cycles of chemotherapy. They're having their staging scans, and they show that their 5-centimeter lesion is now 3.25 centimeters. So where does that put this patient? Is it CR, which is our complete response, PR, which is partial response, PD, which is progressive disease, or OS, which is technically overall survival? But just keep in mind, questions like this could be spelled out, or it might be these acronyms, and you need to know what the acronym means, okay? I got a couple votes. Let's see if some more people can come in with what they think. All right now I'm on a 50-50 split between PR and PD. So why is it not a CR? Let's start there. Why is this patient not a complete response? So complete response, let's see something about 10 millimeters in here. So complete response means that the original tumor is basically gone, and any involved nodes are less than 10 millimeters. So basically, for this to be a complete response, that 5-centimeter lesion would be gone. So we're not that, right? So how do we determine between a PR and a PD at this point? Because y'all seemed a little split on that. Yeah. So PD means progressive disease, right? Something got worse. So that could mean that the original lesion is worse. It got bigger. Or potentially that lesion got better, but there's a new lesion. That would also qualify as being a progressive disease. So for PR, it's kind of in the middle, right? That's the easy way to think about it. Like it got smaller, but it's not gone. And specifically, it's supposed to be less than a 30, it has to have greater than a 30% decrease to be a PR. So that's something else to kind of be thinking about. But exam purposes, I will make it where it's pretty straightforward that you should be able to determine CR, PR, or PD. But RECIST criteria, you need to kind of really be thinking about that and kind of be keeping that here for exam purposes. All right. So what chapter of United States Pharmacopoeia addresses hazardous drugs? Is it USP 797, 795, 800, or 802? Yeah, everybody's getting this one right. USP 800. So USP 800 is the hazardous drugs. USP 797 does what? What's USP 797 about? Sterile. So sterile compounding. What's 795? Non-sterile compounding. And then I made up 802. 802 doesn't exist. All right, good. It's fun to talk. It's good to talk through on these multiple choice questions why things are wrong as well as right, because that also gets you thinking, getting kind of in your head of why reasoning out, because that can help you decide in the future, right? If you kind of get things down between two things, rationalizing why something is wrong might help you if you can't rationalize why something is right. All right, so when does nadir of A and C generally occur? So let's first stop. Nadir, what's nadir mean?
According to Dr. Google, it's the lowest points in any measurement.
Yes, also in my slides too. But nadir means that it's the lowest point. And in this aspect, I'm talking about the nadir of your ANC, which would be the lowest point of your white blood cells and neutrophils, because you need both of those to calculate an ANC. So at that point, so if when does the lowest point of your ANC generally occur? Is it 3 days after chemotherapy, 10 days, 21, or 28? Being a few B's. Yeah. So B is correct. What's our range? Because it's technically a range here, not 7 to 14. Perfect. So I could have any day within that 7 to 14 and it'd be right? So sometimes our bodies don't follow the book completely, so we have a little range there. So most of the time, most chemotherapies nadirs are gonna range between 7 to 14 days after chemotherapy. There are some that are gonna be longer. So there's some drugs that potentially have like a 28-day nadir. So there are some exceptions to that rule just to kind of keep in mind, but majority are going to usually have a nadir within the 7 to 14 days. All right. That's all I got for you. What questions do you guys have for that last part? And any other questions that you have? Would you say if we studied your study guide thoroughly, we would be good for your exam portion? Yes, and even study it according to the exam review would be helpful too. But yes, the study guides are a study guide for a reason. It's basically my slides slimmed down to just the learning objective information. So that is, if you use the study guide, that's why I put it out there. You'll be good. All right. I talk about refer to tables for medications that cause anemia. I think you're referring to the anemia one, that it's the table I brought up earlier that has like iron deficiency anemia. These are the lab values that cause that anemia of chronic disease or anemia of inflammation. These are the lab values, vitamin B12, B, and folate. Those are the ones. Is that the question you're asking about, Medina?
No, that's in your slides, a couple slides that you're asking about your naming of drugs that causes certain, I think it's anemia.
Oh, the drug-induced one?
Yes, and then
There's
you
not tables, there's slides. So there's slide on all 5 of those drug-induced disease states that say these are the most common medications.
right, but you're also talking about either a table or somewhere to go to see the rest of those medications. Do we need to
Oh,
know?
yeah. That is more information. Exam purposes, know what's on the slide because those are the most common. if you want to know about way more of them, then that's in DePiro. So
Okay,
those that table, table, blah 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 blah, whatever number, that's in DePiro. You can refer there because there's a lot more medications, but I listed the most common ones associated with those disease states on the slides. My exam reviews are always helpful. Thanks. Do we need to know them, Medina? Are you talking about the table that was referring to the tables?
thank you.
Okay, perfect. All right. Any other questions, concerns? I have you here. Otherwise, I will post both of these slide sets I went through with the answers. And then whoever is able to join, because the exam review tomorrow I know is optional, because it's just an additional times period that's technically outside of your usually scheduled class, so I can't make it required. But those who are able to join, please join. I encourage you to, but I've already posted my exam review for you. I probably will just be there more for any burning questions that might have developed overnight. I assume it will be recorded. I don't, because they don't give us the option to record or not record anymore. It's like whenever I start the Zoom, it automatically records. So I'm gonna assume it's the same way, Alexis. Okay. All right. Any other questions? All right. Good luck studying. I will post these presentations. Yes, I will post these. Good luck studying. Email me if you have any questions after today or after tomorrow. I will have I'll have my email on my phone. I'll look at it over the weekend if something comes up before Monday. Okay. All right. Have a good rest of your day.